So I will start now, if that's all right. We've got we've got a great turnout today, and I'm sure more people will start as we go, hopefully in the next 2 or 3 minutes. So it gives me great pleasure to have Professor Marilyn Telen. We have a great sort of talks lined up today, and it's entitled The New Therapies of the Future. My name is Subhana Chakraborty. I'm a pediatric hematology consultant at King's College Hospital, part of the Hemoglobinopathy Coordinating Centre in the Southeast London and Southeast of England. And this is our series of education events. Professor Telen has kindly agreed to talk to us along the theme. The theme for the afternoon is Therapies of the Future. And Professor Telen is going to talk to us about that. Professor Telen is the Professor of Medicine in the Division of Hematology in the Duke Comprehensive Sickle Cell Center, Duke University School of Medicine in the US. And so a very warm welcome to Professor Telen, who is an absolute prolific sort of scientist, clinician in the world of sickle cell disease. So welcome to you, and I will hand over the stage to you. Thank you.
Thank you. Let's see now if I can manage to share my screen like I did before. Let's see, put this on. There we go. I think, can someone confirm that they actually can see my screen?
Yes, loud and clear here. You see your screen very well. Thank you.
Right. Okay, thank you. So thank you for letting me give this talk. I'm sorry that I can't do it in person, but in any case, I'm pleased to be here. I think, as everyone in the audience likely knows, sickle cell disease is found in most parts of the world. The US has about 100 to 120,000 people suffering from sickle cell disease. Worldwide, that's about 20 million people. And worldwide, the incidence of births of babies with sickle cell disease is probably between 300 and 310 or 15,000 per year. But most of the people affected by sickle cell disease live in developing countries that have scarce resources to devote to healthcare. And thus, though survival is improving in these countries, especially in African countries and in India, and adults with sickle cell disease are no longer highly unusual in those settings, the average survival with sickle cell disease still means that death occurs during childhood more often than in adulthood in much of the world. But as we do have more people surviving to adulthood, we're actually worldwide facing a higher burden of disease-related complications of sickle cell disease in adult life, with multiple types of end organ damage that cause both shortened survival as well as substantially impaired quality of life. And in addition, sickle cell disease is a very expensive disease for societies on the whole, with the United States alone spending about $1 billion a year on care for individuals with sickle cell disease. So it is totally logical that we thought, and others, people thought a long time ago about whether we could cure sickle cell disease. And of course, the first attempts were with hematopoietic stem cell transplantation, and we're going to hear an update on that, so I'm not going to talk about this very much. But I do want to point out that thus far, although the success rate for this kind of treatment has increased remarkably in the last decade or two, still the treatment has reached relatively small numbers of people, and people of a relatively young age. And although the 2000 number that I have here is a few years old, even if that were to have doubled in the last 4 years, I think the data that I had were 2017, then that's still a small number of people. So under the best circumstances, it's likely that transplantation is going to remain available to only a minority of patients due to both donor availability and the fact that it requires a lot of resources to get the patient through. So gene therapy is another avenue, potential avenue for treatment. And in the United States, the NIH, the National Institutes of Health, have started a rather large program to promote the development of gene therapies for sickle cell disease, and a number of very small trials are ongoing, in addition to the commercially sponsored trial that most people have probably heard of, that is sponsored by Bluebird Bio, and that has certainly been in the news in the United States in the lay press fairly recently because of the occurrence of several cases of myeloid malignancies in patients who've received gene therapy. But nonetheless, I think these trials will continue, and research into how to do this better will continue. In general, gene therapy can take a rather large variety of approaches. They can include addition of a helpful gene, knockdown of a gene such as BCL11A to improve the phenotype by promoting more production of hemoglobin F in that case, direct globin gene editing to correct the mutations, such as changing hemoglobin S to a gene encoding hemoglobin A, or gene editing of globin regulatory elements to partially reverse or the normal hemoglobin switching. The gene addition approach may entail adding a gene encoding gamma globin, a beta gamma hybrid, an anti-sickling beta globin, or simply a normal beta globin. So although gene therapy is improving relatively fast, and certainly faster than I would have predicted 10 years ago, there's still a long way to go. And there's a lot of ongoing research to improve just about every aspect of gene therapy, and they are listed here. So the quality of the gene delivery systems, the best vector for the gene delivery systems, the quality of the hematopoietic stem cells that are harvested, what the best way of doing that is. We know, for example, that certain compounds that have been used in other settings, such as colony stimulating factors to mobilize stem cells, are not tolerated well in sickle cell disease. So the field has moved on to other mechanisms. Optimization of the gene modification system, choice of recombinant pathways, identification of the best gene targets. Is it the hemoglobin gene? Is it BCL11A? Is it something else? Cell manufacturing, how to prepare the bone marrow to receive modified cells, so conditioning regimens, how best to detect off-target effects, especially if we can do it pre-infusion of the treated stem cells, what the best preclinical models for figuring all this out might be. There's still a lot of discussion and uncertainty about how we should define a cure. Do we think that if there are 20 or 30% cells that express something predominantly other than hemoglobin S, is that defined as a cure? What does it take to call it a cure? And then now, how best to avoid myelopoietic malignancies. And at least in the United States, there are active studies, both ongoing and planned, to look at clonal hematopoiesis in sickle cell patients and to try to relate whether or not the presence of clonal hematopoiesis is a risk factor for these myeloid malignancies or not. So all these things are still very much in flux, and for the time being, I think gene therapy is going to consist of perhaps many but relatively small pilot studies, and again, won't reach very many people in the near future. Ultimately, if we are going to reach people in resource-poor settings, we need to have something that I call Star Trek medicine. If anybody ever watched Star Trek, which of course was very popular in the United States, the ship's doctor always had some magic injection that was needed to be given once. It wasn't very hard to receive, and it was totally efficacious. We need gene therapy that will that can be done in vivo, that won't require marrow ablation, or at least to a very minor extent. That would then make it probably possible to spread this therapy to many more places in the world, but that is probably not impossible, but still quite a ways in the future. So I think we have to face the fact that curative therapies are not going to reach most patients with sickle cell disease who are alive today. And so for those patients, we really owe them the development of alternative therapies that both improve survival and improve quality of life. Of course, sickle cell disease presents a lot of challenges. And one is that although it is in a sense a simple disease with an easily identifiable genetic cause, which causes abnormalities in only one cell type in the body, it actually causes profound abnormalities, not only in red cells, but throughout the body. We know that hemoglobin S is unstable, it polymerizes at low oxygen tension, it causes sickling of cells, it causes hemolysis. But the sickle red cell actually has a rather long list of abnormalities that are presumably consequent of that one change. And these include things I've listed here, and probably not everything I've listed, probably more than what I've listed here. But we have abnormal cation content and dehydration, so cellular viscosity increases. We have extracellular exposure of phosphatidylserine, which probably contributes to both adhesion and activation of coagulation. We have metabolic abnormalities that include low ATP and glutathione, as well as abnormally high 2,3-DPG, which actually predisposes to sickling. We see oxidative damage to membranes and membrane instability with abnormal deformability of red cells, even when they are not sickled, an abnormal rheology. The cells are younger, they have higher intracellular signaling activity. That's probably a consequence of both the young age and changes in gene expression regulation due to stress erythropoiesis. We see abnormally increased adhesive properties, again, related to both young age and the signaling activity that we see. We also see red cells involved in abnormal cell-cell signaling. Red cells can activate leukocytes, they can activate endothelial cells, they can probably activate platelets. And we see deficient expression of antioxidant compounds due to alterations in gene regulation and metabolism, with a special role for the NRF2 gene that controls expression of many antioxidant genes. But nonetheless, the red cell is the center of sickle cell disease pathophysiology, and in addition to causing anemia, causes vaso-occlusion, causes acute and chronic tissue damage and vasculopathy, leading to end organ damage. And the pathways that do that are complex, they're multiple, and they're highly interactive. And I show this for a couple of reasons, because first of all, although there's a fair number of arrows in this schema, there actually are much more that one could draw. And this is actually a simplified view of what's going on in sickle cell disease. And so much of what you see here, I've already talked about, the hemolysis, the dehydration, the endothelial dysfunction, activation of coagulation, inflammation, vaso-occlusion, which again leads to ischemia, reperfusion injury, which leads to more inflammation. And I've also thrown in here, though, places where there is at least active development of therapeutic agents. So for adhesive interactions, there has been work on anti-selectins as well as molecules that inhibit signaling. For sickling, there has, of course, been hydroxyurea. There's been other agents that increase hemoglobin F that have been explored. There have been agents that decrease sickling, such as Voxelotor, that at least in the United States is FDA approved and available, although expensive. So these exist. In trying to counter free hemoglobin, which does actually, one of the arrows that's not very really clear here is that free hemoglobin feeds into inflammation. There are investigators looking into the possibility of treating patients with hemopexin or haptoglobin, at least in certain settings. There's active investigation looking at the possible utility of antioxidants, and L-glutamine, or Endari, which is approved in the United States, is one of those compounds that is available, again, very expensive, but available in the United States. There are anticoagulants, which have intermittently received a lot of attention, both the traditional anticoagulants and antiplatelet agents that may have possible utility, although thus far they've been, I would say, disappointing in their utility. And then other anti-inflammatory agents have been looked at, and there are several companies that are developing them, although they're in very early stages. So if we have a limited ability to affect the root cause, which is expression of hemoglobin S, the question does arise, how can we do the most good for the most people alive today? And to answer that question, we need to understand both what disease-related events are most bothersome to patients with sickle cell disease and what sequelae are most associated with mortality. So this graph comes from a paper by Chaturvedi from 2018, and he showed, I don't know actually if it's a he or a she, I guess, but showed very clearly that if you had more than one impaired organ, your mortality was greatly increased, so that if you had no organ impairment, your survival curve looked like this. But if you had one or more organ impairments, and this included decreased lung capacity, increased tricuspid regurgitant jet velocity, proteinuria, or increased creatinine, then your survival was much reduced. Another study from our group in the US did something similar to that, looking at a cohort of patients followed for about 10 years, and again showed that there were statistically important relationships of between mortality and certain kinds of end organ damage. Again, pulmonary hypertension, which has been shown in many studies to be related, proteinuria, almost any cerebrovascular event. The definition of cerebrovascular event here included stroke, seizures, and TIAs, with seizures and strokes being strongly related to mortality. Admissions or frequency of vaso-occlusive events was related, and some of these other things were related to some extent. And so the survival is related to a frequency of vaso-occlusion, or VOC. And here is the survival curve looking at patients who've had 4 or less or fewer VOC events in a year versus those who've had more than 4 events in a year. And again shows a decrease in survival with more frequent events. So when we think about the sequelae of sickle cell disease and what we would like therapies to address, we certainly want to address the anemia. We want to address the vaso-occlusion, both because it is top or near top of the patient's list along with fatigue, but it's also, we know, associated with mortality. Acute chest syndrome, which remains an important cause of acute mortality, stroke, nephropathy, pulmonary hypertension, neurocognitive decline, and CNS events in general. And hopefully addressing those things would address premature mortality. So in order to do that, we need to understand both the mechanism of the process of hemolysis and vaso-occlusion, but also how it specifically occurs in different organ systems. Because if we don't understand that, we won't really identify good druggable targets and develop both trials and treatment modalities addressing these targets. So just a quick review, hydroxyurea, which has been available in the United States for more than 2 decades now, or 3, I suppose, has done a lot to improve the lives of patients with sickle cell disease. It improves the anemia, reduces the hemolysis, reduces the frequency of vaso-occlusion for many patients, reduces the frequency of acute chest syndrome, has unclear benefit, if any, on stroke, nephropathy, and pulmonary hypertension, which again are important both as quality of life and as markers for early mortality. Some patients report improvement in fatigue and quality of life, and we have seen studies, especially a nice one from Greece, that showed clearly that it was hydroxyurea was associated with reduction in mortality. But there are challenges to hydroxyurea, and they include those revolving around reproduction and fertility, pregnancy, spermatogenesis, whether or not it decreases ovarian reserve, which is decreased in sickle cell disease in any case, probably, whether long-term outcomes such as stem cell production and myelodysplasia and progression to leukemia are related to hydroxyurea. How best to manage the drug, whether we should do what many people in the United States advocate, which is to titrate it to a maximal tolerated dose, or whether we should take a more practical approach like they've done in studies in Africa, where they've used a fixed dose that they feel is reliably safe, and which they've also shown it can be both safe and efficacious. And then furthermore, how do we address the possibility of providing our patients with combination therapy, which at least for the moment can include in the United States, the FDA-approved drugs of L-glutamine, crizanlizumab, and Voxelotor. L-glutamine being an antioxidant drug, crizanlizumab an anti-selectin drug, and Voxelotor an anti-sickling drug. So to look at what Voxelotor does, there's perhaps not as much published on Voxelotor as one would like to see, but clearly it is a drug that improves anemia and reduces hemolysis in most patients who take it. And there's some recent data I'll show you that suggests that it has at least some effect on vaso-occlusion, but the initial study that led to FDA approval did not claim that. as an indication. And there's no data that it affects any of the other things on our list for what we need to fix. This is the more recent data on association of Voxelotor therapy and vaso-occlusion. And what it really does is it shows response, the relationship of response to Voxelotor to vaso-occlusion. So it appears that the patients who achieved the highest hemoglobins here and then the next highest here had lower time to vaso-occlusion, or lower frequency of vaso-occlusion. So perhaps that those data will come out even stronger as time goes on, as studies are continuing. But this was an abstract. L-glutamine, again, the antioxidant drug, was approved by our FDA with 2 indications: that it decreases vaso-occlusion by a relatively modest 20–25%, and it decreases the frequency of acute chest syndrome, which is important. And a recent paper by Ilbadou et al. This year is interesting because it I think helps elucidate the mechanism why it might be the case that this drug actually works to do these things. But again, there's no evidence that this drug is going to affect any of the other endpoints on our list. It might, but there has not been the kind of studies that are designed to show that it does. And so we have really no data for all the things listed in white, including anemia and hemolysis. Crizanlizumab, the anti-selectin drug, which is an intravenous preparation, again, was approved because it did decrease the frequency of vaso-occlusion. It did not affect anemia or hemolysis rate. And again, there's no data suggesting so far that it improves anything else on this list, including chronic pain or quality of life. So where do we go from here? We need to continue to develop a better understanding of the mechanisms leading to organ dysfunction. We need, I think, to develop an evidence-based assessment system of risk for acute and chronic organ dysfunction, mainly because with the relatively small populations available for in-depth studies, mainly in high-resource countries, if we don't have efficient and well-designed clinical trials, we will never get data for the kinds of things I've listed in the previous slides. And finally, we need to understand mechanisms and relationship of mechanisms to specific organ dysfunctions in order to adopt a multi-agent therapy that is based on risk factors and mechanisms, as opposed to, well, what's the next drug on our list, with no particular reason for choosing one over the other. So although we now have 4 approved drugs for sickle cell disease, as you can see, we only have a limited amount of data on how they help patients. One interesting avenue is to address the P50 of hemoglobin, which sickle hemoglobin, which promotes early deoxygenation and the sickling, and also the oxidative stress and metabolic abnormalities of the sickle red cell. So hemoglobin S red cells contain significantly more 2,3-DPG than do normal hemoglobin A red cells. Thus, they have a shifted O2 dissociation curve, and that promotes early oxygen release. And they also have reduced ATP stores, and that promotes membrane damage, loss of elasticity, and metabolic fragility of the cells. This is a very abbreviated schema of the pyruvate kinase the role of pyruvate kinase in the glycolytic pathway, because a lot of attention is being paid now to development of drugs which actually activate pyruvate kinase at the end of this pathway. And what you can see here is that as glucose goes down the glycolytic pathway, 2,3-DPG is produced, which promotes oxygen release from hemoglobin to deoxyhemoglobin. An intermediate is phosphoenol pyruvate, and then red cell pyruvate kinase, or PKR, then converts phosphoenol pyruvate to pyruvate, and in the process of that converts ADP to ATP. And so when you increase pyruvate kinase activity, you actually somewhat deplete this side pathway leading to 2,3-DPG, and you promote production of ATP. And so there are several ongoing studies now of drugs which do that. Basically, there are two companies I'm aware of that are conducting these studies. One is Agios, which is conducting a study of Mitapivat. This is a drug that was initially studied for pyruvate kinase deficiency and is now being studied and has been studied in sickle cell disease. And then Forma Therapeutics is looking at another drug that also is a pyruvate kinase activator, and they started their studies past the healthy volunteers in sickle cell patients. And in both drugs in the phase 1 studies of patients with sickle cell disease, reduce 2,3-DPG, increase ATP, increase hemoglobin by at least 1 gram in most subjects, and decrease hemolytic markers. And this is taken from the American Society of Hematology meeting this past December for Mitapivat, the Agios drug. And what you can see is that here the 2,3-DPG shows a dose-related decrease. This is as the dose increases in a BID dosing, you see further decreases in the 2,3-DPG level that returns when the patient stopped taking the drug. In the opposite fashion, as you increase the drug, ATP levels in red cells go up and then return to normal when the patients are off the drug. With increased doses, you see increases in hemoglobin, and although there's quite a bit of variability, it's an appreciable increase here. And so you see that the maximal increase they saw, and this was, I believe, in a 2-week dosing, was 1.3 grams per deciliter, and over 50% of patients had that increase of over 1 gram per deciliter. And the maximal increase was 1.9 grams per deciliter. The Etavopivat or FT4202 drug had a similar response. These are presented somewhat differently, but again, looking at 2 doses over now 21 days, over 14 days again, the 2,3-DPG went down and then slowly rose after the termination of therapy. And then the ATP rose and then slowly went down after termination of therapy. They showed very nicely that they were able to increase the activity of pyruvate kinase from pre-dose levels to substantially increased levels. And again, similar to the Mitapivat, their maximal hemoglobin increase for each patient was about 1.5 grams, and 7 out of 8 patients saw greater than 1 gram per deciliter increase in hemoglobin, and the maximum hemoglobin increase in subjects with a greater than 1 gram per deciliter response was actually 1.6 grams. So, so these drugs both did, I think, exactly what the various pharmaceutical companies hoped they were going to do. They increased ATP content, they increased hemoglobin levels, and I didn't show this to you, but in both cases they improved markers of hemolysis, such as LDH, for example, and they decreased reticulocyte count, as you might expect. In the case of Etavopivat, the trial also showed that they increased red cell deformability as measured by ectocytometry, and decreased the point of sickling, meaning that in an ectocytometer where you control oxygen tension, it took a lower oxygen tension to make the red cells sickle. Agios is continuing their study. They're still in a phase 1 study. Forma is going to a phase 2/3 study that is, I think, started already in a couple of sites, but is basically ramping up now. That the company hopes will lead to their FDA application for approval of the drug. But in any case, I think this is a very promising drug at this point. I just want to spend a minute or two on acute chest syndrome, which is still one of the most common acute events that leads to mortality in both children and adults. Typically presents with hypoxemia and pulmonary infiltrates and can cause a rapidly downhill course. And although 2 of the drugs we have available, hydroxyurea and L-glutamine, reduce the frequency of acute chest syndrome, it still happens. And a number of investigators have worked hard on trying to understand what's happening in the lung with acute chest syndrome. I think the concept now is that extracellular heme and the consequent inflammation that the extracellular heme can cause is very important to the pathophysiology of acute chest syndrome. And so possible interventions could include things like haptoglobin and hemopexin infusions, things which increase heme oxygenase 1 activity, drugs which inhibit TRL4 or P-selectin, and activation of NRF2, which is the kind of master control gene for antioxidant genes. And unfortunately, if you look at least in the clinicaltrials.gov site and search for acute chest syndrome, you will not find active clinical trials, but I do believe these things are under investigation, and hopefully we will see some clinical trials in the not too distant future addressing acute chest syndrome. And one of the other things that we've known about for a long time and don't know much about how to do it is sickle cell nephropathy. We know that macroalbuminuria is fairly common. It's age-related and it's related to decline in renal function. And at least in the United States, it's fairly common that physicians use either ACE inhibitors or angiotensin receptor blockade therapy when proteinuria is present. But we don't have an abundance of evidence that tells us what we're achieving with those therapies. We're doing it as much in analogy to using those drugs for other proteinuric syndromes such as diabetic nephropathy. But we do know that nephropathy is highly associated with premature mortality, and that survival once chronic kidney disease develops is severely limited. Our group looked at the rate of annual GFR, glomerular filtration rate decline in sickle cell patients to see if we could identify patients that are high risk of rapid renal function decline in order to target therapies and trials to the population at most risk. And just briefly, we found 7 variables that correlated in cumulative fashion with rapid renal function decline, and the graph where you accumulate a point for each one raises the risk from under 20% to over 50%. This, of course, needs to be validated in prospective studies, but gives some hope that if we have a drug whose mechanism we think is applicable to kidney disease and sickle cell, then we should be able to identify those patients in whom we are most likely to see a response. Whether those drugs will be ones that inhibit hemolysis or oxidative stress or inflammatory pathways, we don't really know at this point. But we do need to be able to identify trials that are doable in order to determine what drugs would work. And to have trials that are doable in a limited population, we need risk stratification. So thus far, I think it's very important to think about multi-agent therapy. We now have more than one drug. That's taken a long time, but it finally happened. We have other drugs on the horizon, and there are very active research among a lot of pharmaceutical companies to develop more drugs, to repurpose some drugs, some of them affecting, for example, the nitric oxide involving pathways like riociguat and drugs in that class of compounds. But we really need to understand how best to combine the drugs. The ones that are approved were all studied in the presence or absence of hydroxyurea and showed similar effects, but that doesn't answer the question of when you have a patient who needs more than just hydroxyurea, what is your best next choice in that particular patient? And so we need to understand more about how patients respond to these drugs, which drugs they respond to, either by with their hemoglobin level or changes in their hemoglobin P50, markers of oxidative stress, markers of inflammation, their hematologic blood counts, markers of hemolysis, frequency of pain crises, end organ damage, and quality of life all need to be addressed, and multi-agent therapy needs to be optimized according to which the clinician feels are most critical to address. So I think the health of the millions of patients living with sickle cell disease today really depends on the success of developing and delivering targeted and multi-agent therapeutic approaches to the sequelae of having red cells with predominantly hemoglobin S. And I will end there. Thank you.
Thank you, Professor Telen. That was fantastic. Thank you. We've got lots of virtual claps as well.
Thank you.
I will open the floor to questions. Is there any questions for Dr. Telen? Whilst people are thinking of their questions, maybe I could start with one. So there are a number of drugs that have addressed the intracellular sickling. If you you can argue the sort of core of the main problem in sickle cell, where the cells, where the hemoglobin polymerizes and precipitates, or to that, just or addresses. So, for instance, in your example of the pyruvate kinase, increasing the pyruvate kinase activity, causing the right shift of the oxygen dissociation curve for hemoglobin S. So I guess we have the same with Voxelotor, where the hemoglobin dissociation curve shifts to the right, and to a certain extent, I would imagine that with hydroxyurea as well. So my question is, on one hand, you have a hemoglobin which is which is a higher affinity to oxygen. You have a high affinity hemoglobin, which then the sort of oxygen delivery to the end organs is limited or reduced compared to hemoglobin S. And how do you square that? How does that get overridden? Or the kind of, how do you how does that work? That despite having less release of oxygen, that overall it is a better sort of physiological situation?
Yeah, I think that is a really good question, and it's been the subject of sort of pro and con papers published by others. Bob Hebel, I think, was the author of one that raised exactly your question. That was published a few years ago, I guess. And he, said, well, especially in those organs at most risk due to high oxygen consumption and/or an acidic environment, so think brain and kidney, really, doesn't this pose a problem? And another scientist who I think actually works for, or at the time was working for, the company that produced Voxelotor, responded that this was mainly compensated by the higher hemoglobin level. But I think what's disappointing is that we don't have the studies. I think anybody who has participated in or read clinical studies knows that because something makes sense doesn't actually mean that's what happens in a clinical study when you actually look in real world. And we just don't have the real world evidence to any great extent to be comfortable that there is a benefit to particularly those organs when it comes to something like Voxelotor. And also, in theory anyway, Voxelotor could be pushed to reduce the to increase the oxygen affinity more than one would really want to. So it's possible to essentially overdose on Voxelotor. And that's a little disturbing too, because it's kind of like carbon monoxide poisoning, really. I think what's intriguing to me about the pyruvate kinase activator drugs is that they seem to, for reasons, I guess, of the capacity of the glycolytic system, they only push the 2,3-DPG down to normal level. They don't. None of their data show any 2,3-DPG going below that normal level, and that's, I think, comforting, I guess. And then they have a bimodal mode of action because they increase ATP, and they've shown data that they improve a whole bunch of other parameters related to kind of red cell biology, including antioxidant capacity and rheology and things like that. And there's no data that I know of for that with Voxelotor, which of course may or may not affect anything downstream. What we don't know is whether the degree to which Voxelotor reduces sickling is enough to reduce oxidative damage in the red cell. So we don't really understand to what extent it may prevent sickling, but to what extent does it reduce the other things that are going on in the red cell and the cytoskeleton and things like that. And that hasn't been published that I know of. And so you know, it may or may not have beneficial downstream effects other than kind of simply, if you will, it's not so simple, but simply, you know, reducing sickling. It's a good question.
It's a very good answer. Thank you. I don't see any hands up for any other questions. I will maybe, for the interest of time, just have one more question from me. Oh, there is one question.
Oh, Sabana, there are questions in the chat.
On through, and sorry. So there's question in chat. I'm terrible. I'm terrible.
Questions in the chat.
Sorry.
Will I read it out instead?
Yes, please, sir.
So in the algorithm to predict the rapid decline in EGFR, was it a low or high platelet count which was predictive of a rapid decline?
Did you hear that?
Yes, a high platelet count.
Oh, high. And presumably low BMI, low hemoglobin, low retics.
The only unexpected thing that I think is untrue is that, oddly enough, it was a higher BMI that was favorable and a low BMI that was unfavorable. Everything else kind of went in the direction you would expect, I guess, is correlating with disease severity. And we kind of hypothesized that the detrimental effect of low BMI might be a reflection of disease severity, actually, as opposed to, you know, the high BMI we generally think of as unhealthy, you know.
Yeah, absolutely.
Can I just quickly squeeze in my question, because it was related to that as well? So I know I'm jumping the queue a little bit there, but it was just on those renal markers. A lot of them seem to be going in the same direction as what alpha thalassemia would induce in the red cell markers or general markers. And obviously alpha thalassemia is thought to be an important factor in protecting against renal disease. And I just wondered if you'd controlled for that as well in your data set and whether it just fell out.
We controlled for a bunch of things, but and I'm pretty sure we looked at it separately, but we did not, I'm pretty sure we did not control for that in the risk score. And that may be because it didn't show enough of an effect in our single gene association studies.
Okay.
Because all these, I mean, I must admit when we did this study, our alpha thal diagnosis, which was not done routinely in our clinical setting, you know, is largely based on MCV and a combination of MCV and iron status. But we actually now do have whole genome sequencing on all these patients. And so, whereas before we had GWAS. So I think, you know, it may be worth going back and seeing if we can determine that more strictly than we had before.
Thank you.
Thank you. Have I missed any other hands? No, I don't think I have. So that leads me to thank Dr. Telen profusely for this really fantastic talk. I'm really grateful for your time.
My pleasure.
Yes, thank you very much. Can I also just remind all the audience today, we have a fantastic turnout, to please complete their assessment forms at the end of the meeting, and give us some more ideas of what you want to be hearing in the future. So thank you very much. Dr. Telen. I'm going to now move on to the next speaker, if I may. And again, I'm delighted to introduce, is Dr. Potter here? Yes,
I am.
Dr. Potter is here, wonderful. I'm delighted to introduce Dr. Victoria Potter, who is the Bone Marrow Transplant Director at King's College Hospital, and for 10 tireless years has fought and successfully fought to get NHS approval for adult bone marrow transplant, which is just about to kick off. and Dr. Potter is going to give us an update of bone marrow transplant in sickle cell disease, and I imagine that will be more focused on adult patients. So over to you, Dr. Potter.
Thanks very much, Sabana. So yes, I'm going to talk about transplantation for adults, and we did cover some of this in the recent UK Haemoglobinopathy Forum, so apologies to those of you who have seen some of this before. I'm just sharing my screen now, so hopefully this works. Is anything happening?
Yes, we can see your screen. If you do the presentation mode, then we'll be ready to go. Thank you, Victoria.
Is that right now? Is that all right, Sabana?
Yep, that looks good.
Okay, perfect. All right. Thanks very much for the invitation to speak this afternoon. So I suppose the first thing that we should think about is why are we talking about this for sickle cell disease? And I suppose, you know, we've had a fantastic talk just now on all of the advances in care and some of the new things that are going to be coming. But despite these advances, the use of hydroxycarbamide, which is really one of the only two things we can do at the moment in the UK, certainly on the NHS, life expectancy does remain shortened in patients with sickle cell disease. And in addition to that, significant morbidity occurs in these patients with complications. The resource implications are very large, so patients are coming frequently into hospital. There's a huge impact upon NHS services, but also for those patients and their ability to work and to contribute to society and to participate and have family life as they would want to. There are significant issues and limitations on their ability to do all of that. Now, this is a talk today about therapies of the future. Well, actually, transplant's not really a therapy of the future. It's actually been established for many, many years and is done in many, many other countries. But in the UK, it's really only been for children. So for us to be able to introduce it for adults is a big step forward. And why have we been able to do that? So one of the reasons and one of the concerns about why it really hasn't been very well established in adults was that actually as these patients become older, they get accumulated comorbidities of sickle cell disease. And transplants and intensive therapy and delivering high doses of chemotherapy can actually be really quite complicated in patients who may have organ impairment or other issues. So for adults, there are potentially significant risks of transplants given those accumulated comorbidities. Now that all changed really with the introduction of reduced intensity transplants, and one of the pioneering protocols has been from the NIH group, which introduced not only a reduced intensity but a very non-myeloablative approach. And this therefore actually makes it safe to deliver in patients who may have other comorbidities accumulated, which is typically the adult group. And that and other accumulating data, which we'll talk about, has led to it being approved, very excitingly, really only last year for adults in the UK. So this is a big step forward in terms of something we can actually offer to this patient group. So what are the principles here? Well, it is a curative therapy, and it's the only established current curative therapy for patients with sickle cell disease. So we can potentially offer patients the chance to be cured, and not really any other therapy does that. We've got these advances in transplant conditioning, so that's now improved our ability to deliver this therapy. And as I said before, you really need to deliver a reduced intensity or a non-myeloablative, so a protocol that doesn't have particularly high doses of chemotherapy or toxicities associated with it if you're going to do this for adult patients. Now, one of the differences between doing transplants for sickle cell disease, which is a non-malignant disease, is that you don't necessarily need full donor chimerism. So all you need is enough donor engraftment and chimerism to actually reduce the sickle burden. And a really important principle is that giving a patient GVHD is a bit of a disaster. There's no advantage for a patient having graft versus host disease as a complication of transplant in any patient who has a transplant for a non-malignant disease, and it would be really terrible if a patient had sickle cell disease only to swap it for the chronic disease of graft versus host disease. So really we have to minimise that at all costs. And the other most important principle is to remember that transplants are treatment for severe sickle cell disease. Despite the fact that I just spoke that we now have a potentially tolerable, good transplant protocol and a way to do this that's much safer than previously, you're not going to offer this to everybody. So when you're talking to your patients, you really have to have severe sickle cell disease for this to be a treatment consideration. So what are the indications? Well, really, there are two broad indications that we're talking about. So one is patients who have sickle cell that are at high risk for disease-related morbidity or mortality that are defined by end organ damage. And there are a number of things here, such as stroke or pulmonary hypertension or end organ damage as hepatopathy, that would mean that these patients are likely to have ongoing complications and suffer from morbidity and mortality related to sickle cell disease. The other group of patients is patients who've got reversible complications that are actually not treatable by an exchange program or by hydroxycarbamide. And most typically, this would include a group that were having a recurrent vaso-occlusive crisis or recurrent chest syndrome. And there are a number of criteria in the commissioning policy. So you can't just have had one vaso-occlusive crisis in your life. You need to have had a number of these not treatable in any other way to be considered severe enough. And again, for adults, so those are the indications for sickle cell disease, but at the moment for adults in the UK, it's only routinely funded for those with sibling donors. So if a patient doesn't have a fully matched sibling donor, at the moment we're not able to routinely offer a transplant to this group of patients, even if they do have severe disease. So these are the current NHS England commissioning criteria. And you can see what I said before, they've actually specified certain things. So for example, I said you can't have one chest crisis. So the current criteria is 2 acute chest syndromes despite optimum treatment with hydroxycarbamide or transfusion therapy. For pain crises, it's 3 per year, despite institution of other optimal therapies. So there are some fairly specific criteria that really pull out this group of patients that have severe disease. So this is the pivotal paper and the pivotal publication of a newer transplant protocol that actually established this therapy, and this was published in 2009, and it has taken us quite some time to be able to get the accumulated evidence that's been able to convince the NHS that this is worthy. And there are a couple of interesting things to talk about. So this is actually what the transplant looks like. So the two things we're thinking about doing before transplant, hydroxyurea before the transplant and red cell exchange. So you have to optimize the patient before you even start to do the transplant. And this involves alemtuzumab, or some people will know this as Campath. This is a very immunosuppressive agent, but it does not really alter blood counts significantly. So it's not really a chemotherapy. So this is purely a protocol based upon immunosuppressing patients, such as when you infuse stem cells, they're able to engraft. There's a very small dose of TBI, so that stands for total body uration. This is a tiny dose that's associated with minimal side effects, and again really does not have very significant effects on blood counts. This protocol involves a GCSF mobilized peripheral blood stem cell infusion, and the interesting point about that is that many sibling donors may well have sickle cell tray, and there's potentially been concerns about, does this actually cause a problem? And GCSF have now been used multiply in patients that have donors with sickle cell tray with actually no adverse effects. And the immunosuppressive agent in this protocol is sirolimus, and that is continued, and most of patients who are receiving this transplant will be upon that drug for about a year. One of the other things, so supportive care is really important in all transplant patients. The platelet threshold for this protocol has been established at 50, and that's due to concerns around potential CNS complications. But actually, there are a certain percentage of patients receiving this protocol who don't even ever need a platelet transfusion to maintain that. And the planned taper of immunosuppression, as I said, is planned at 1 year post-transplant. So that's that. This is the initial group, and when they published this initially, they only published 10 patients. And you can see here the reasons for those transplant would mirror what we expect to see. So things like stroke or frequent vaso-occlusive crisis. And there was a number of age is in this group, and in the initial publication, the age went up to 45. Now, this is the sorts of things you see after a transplant. So you see what I talked about before, that CD3 T cell chimerism, and you see typically mixed T cell chimerism, but also you don't see completely full donor myeloid or CD15 chimerism. And the patients do not need that to actually be considered cured or to not have sickle cell complications. You can see the hemoglobin rising post-transplant in that second slide. And you can see other parameters such as parameters of hemolysis improving post-transplant. Now, this is one of the really interesting things, or one of the things we need to consider, is actually when they published this original publication, they actually performed HLA typing in 69 siblings and 112 patients. So it started with 112 patients, and 88 of those patients, so the vast majority, did not have a fully match related donor. So they identified 24 patients eligible, but actually by the time they went through the process, there was only 10 that underwent transplantation. So this is a great protocol, but it's probably not something we're going to be able to do for everybody, and that's purely due to the fact that people don't actually have fully matched sibling donors. And we'll come back to what the alternatives are later. So in 2021, there's actually been a recent update on this protocol. So now this has been the largest series of patients, and this was patients from the original NIH center from Chicago and from a center in Saudi Arabia, and they've combined their cases and they've now transplanted 122 patients with this protocol. And so in this update, the 5-year overall survival is pretty good, 93%. The 1-year overall survival was 98%. So you can get patients through this protocol without significant problems. Some people have graft failure and do relapse their sickles, so that leads to a decrease in the sickle cell survival, and at 5 years, the sickle-free survival was 85%. Interestingly, in this group, nearly 50% of patients were older than the age of 30 and 17% of patients older than the age of 40. So actually, it's definitely an adult population when we're looking at that. And so that's quite useful in terms of when we're actually talking to our adult patients about this, because when you look at many other series, you know, there's a lot of younger people and they will do better with transplantation than older groups. So this is a nice cohort to look at, and that it probably does reflect the age of the patient population we'll be looking at. So you can see there in that graph some of the issues. So they had 122 patients who had a sibling transplant. Actually, 16 patients had graft failure. So then you have to think about what's actually going to happen to a patient if they get graft failure. Well, one patient in that series did actually die of marrow aplasia and sepsis. So that's definitely a death from a transplant complication. People who have graft failure, some of them will get sickle cell recurrence and will be fine and will go on to receive sickle-specific therapy. And most patients should have minimal toxicities from the chemotherapy. But if they do have sickle cell recurrence, they can then potentially die from sickle cell complications. 2 patients in this series actually went on to develop MDS, and there was another patient who had CML, which we don't think is actually related to the protocol, but important to know. And these are all things that we need to actually talk about the patients. And you can see there the 103 correlated to their 5-year overall survival. Really importantly, in this update, the GVHD rates remain low. And I said before, it would be a disaster if we cure sickle cell disease and give patients graft versus host disease, but there was only 2% who had acute and actually no chronic GVHD reported in this protocol. So that's actually really encouraging. And another encouraging fact is that 21 pregnancies from 7 males and 7 females. So an important issue for our patients is obviously fertility. And we think that this protocol actually leads to an ability to have successful pregnancies. And so it's actually reassuring to actually see that a number of pregnancies have been reported in patients who've received a transplant using this protocol. One of the other things, and this is a different study, this is a smaller study, but again, looking at this non-myeloablative protocol with the alemtuzumab, is that actually there have been studies looking at quality of life, and you see improvements in quality of life post-transplant across a number of parameters, including things like social functioning, and really importantly, body pain. And you can see there the scores going up. This is probably the biggest study on sibling transplants. So this is 1,000 patients HLA identical sibling transplants. This is a range of transplant protocols. So it's not the adult protocol that I've just spent some time talking about. It's actually patients across a number of centres. So it's a international survey of sibling transplantation. And you can see there the 5-year overall survival, 95% less than 16 years, but 81% of patients greater than 16 years. And the GVHD-free survival, again, very encouraging, but you can see that drop off with age. But these, I think, kind of affirm the testament that actually with a fully matched sibling, this is something that does offer a chance of cure with good results in the longer term. So this has led to this exciting development that we're now actually able to talk about this and offer this to suitable patients with severe sickle cell disease. So you will remember before I showed you that dreadful slide where they screened 122 patients and only 10 went on to get a transplant. Well, the reality is that actually most patients do not have a fully matched sibling. So what else are your other options? Well, one option is a half match. So a person who's related to someone, but it's only a 50% match. This is called a haploidentical transplant. And this can be a parent, it can be a sister, it can be a sibling. It can even be a child for an adult patient. So this is a really important option to try and expand the donor pool and make transplant an applicable option for more patients. And you can do this with a protocol using post-transplant cyclophosphamide. So you can see here already there's a bit more involved in this type of protocol. So this protocol involves more chemotherapy up front. So there's fludarabine, there's cyclophosphamide, there's an immunosuppressive drug in the form of ATG. And after the transplant, in order to get the graft to work, they get higher doses of cyclophosphamide. Now, the reason for this is that cyclophosphamide is thought to inhibit rapidly proliferating T cells. So the T cells that cause GVHD are meant to get knocked out when you deliver the cyclophosphamide on day 3 and 4, allowing a state of tolerance. And that's really important. You can't really do a haploidentical transplant safely without giving post-transplant cyclophosphamide. So there's a bit more involved here. Now, this is one of the original publications in adults. So this is an adult publication. The median age of this publication is 13. And you can see here that of the 19 patients they screened, they're actually able to transplant 17 of them. So already much more, even though they screened many less patients. The problem here was actually graft failure. So this was proven to be a safe protocol. GVHD appeared to be limited. No one actually died, but 43% of patients actually rejected their graft. And this is pretty unacceptable because I don't think I feel very comfortable talking to a patient and offering the transplant, telling them, actually, do you know what? There's a 43% chance that you'll still end up with sickle cell disease after this. And I'm pretty sure most patients are going to find that fairly unacceptable. Now, there have been some modifications to this protocol, so adding in more chemotherapy in the form of Therapies does actually improve engraftment, and this is from a study published last year, which actually shows you can actually get patients to engraft, but again, it's a more intensive approach, and that may not be acceptable, and it may not be easily tolerated by many adults with sickle transplant. But you can see here in this publication, they report very good overall and event-free survival. So haploidentical is an option. And again, while there was some acute GVHD, rates of chronic GVHD were relatively low using this approach. So if we don't have a haplo, or we think that a haplo is of concern and you don't have a sibling, people often say, well, what about an unrelated donor transplant? And the real issue here is graft versus host disease. Now, we emphasized before that that's a problem. We don't want patients to have graft versus host disease, but you can actually see here, this was FMC conditioning in 30 children. And while the overall survival rates are pretty good and the event-free survival rates are good, chronic GVHD at 1 year was 62%. And in this publication, 7 patients actually died from GVHD. And there were probably some problems with the way they delivered the conditioning, and there are probably some ways to minimise that. But it's a big enough concern to make you think very, very hard about whether you would want to consider an unrelated donor. The other limitation to unrelated donors is that actually many patients with sickle cell disease will not actually be able to find an unrelated donor on the registry, and that's basically due to the makeup of the current registry for patients with sickle cell disease due to ethnicity. This was another comparison. So this is the American registry who did a big international comparison of the different donor types. And I suppose it really kind of confirms some of the things that what you said. So they wanted to look at the different donor types and conditioning intensity. So they had 558 matched siblings. They had 137 patients receiving haploidentical transplants and another 214 who had either a fully matched unrelated or a mismatched unrelated donor. And really what that shows is what I was saying before. So siblings had really, really good outcomes. For those who didn't have a sibling, the data didn't really favour one alternative donor over the other. But for unrelated donor transplants, there were significant differences in graft versus host disease. So if you had a fully matched unrelated donor, your risk of getting GVHD was nearly 4 times higher than if you didn't. And if you had a mismatched unrelated donor, that was almost 6 times higher. So GVHD is a problem when you don't have a fully matched sibling or a haploidentical donor. If we had to summarise where we are now from a transplant point of view and from a donor point of view, this is the summary. So patients who've got a fully matched sibling, donor availability is low, but the protocols are actually good and these patients do really, really well. Low rates of complications from transplant and very low rates of GVHD, and there's accumulated data with a long follow-up. For haploidentical transplants, the donor availability is actually very high, and the vast majority of patients we can probably identify a haploidentical donor in. But the studies are fewer and more recent, so the follow-up is longer. We are worried still about graft rejection, although we have been able to improve that. But for adults, you know, it's a more intense conditioning protocol, and we really need to see more data before we would be satisfied that that is a good option. For unrelated donor transplants, donor availability is again limited follow-up, and the issue there, as I said, is graft versus host disease. So that's probably the broad summary. But I think it's fair to say that as we continue to evolve our approaches and we continue to evolve our protocols, the indications will remain fluid. For adults, we need to understand that increasing age at transplant, and if we don't have good HLA matching, that will increase the risks of organ toxicity, GVHD, morbidity, and transplant-related mortality. And for some patients, it may well be better to live with the chronic effects of sickle cell than to go through a transplant that has too many risks. For us in the UK, I think there are some unanswered questions that we haven't really kind of nutted out yet. So people can now you can now have a transplant if you're a child or you're an adult, but if you've got a child at the age of 18, where is that best done? Is that best done in an adult or a paediatric centre? What is the best protocol? Are we aiming for a national UK approach? And I think the answer to that is yes. We have now, reporting the NHB, established a UK collaborative transplant group where we're going to meet regularly and really try and aim to be really collaborative and make sure we're talking about our outcomes and we're all using the same protocol. Important questions are, how does transplant fit in the context of the new drugs available? And that's going to continue to change with time as we get more evidence and they're more established and what becomes available and what becomes funded in the NHS. Another important question is, where does transplant fit in the context of gene therapy? At the current time, I'd say that transplant's a much more established therapy, and gene therapy, although promising, is likely to be incredibly expensive, and we'll have to work out how that fits in going forward. UK patients, this is what's happening now. Transplants are usually agreed locally via the local HCC, then they're agreed by the National Haemoglobinopathy Panel. So all adult transplants have to be agreed by the UK National Panel before proceeding to transplant. They will then go on to have joint consultations with transplant and sickle cell physicians. They'll again be looked at the local transplant MDT. Currently only funded for siblings, important issues around optimising the pre-transplant status. We have agreed in the UK to all collaborate and use the NIH protocol as it appears the safest and the easiest to deliver. One of the commissioning requirements is that transplants does occur in centres with joint sickle and transplant expertise. For patients who do not have a fully matched sibling donor, we do want to be able to take forward transplant for those, but we do need to gather more data, and we're awaiting news re being able to do these patients as part of a clinical trial where we think that is clinically appropriate. So I think that's all I have to say, except to conclude, I think this really is an important therapeutic option. The current protocols do result in high rates of overall survival. These approaches for siblings are particularly promising. We don't need full donor chimerism, and funding for adults does remain a major limiting factor, given that it's only funded for siblings. And if we're going to develop these transplant approaches further, we're going to need to be able to fund that for a broader population of patients who do not have a sibling donor. So I think I'll end there, and we will maybe go for questions now.
Thank you very much, Victoria. I hope you can hear me. Given that Dr. Telen is still here, and thank you for staying behind for this talk as well, Dr. Telen, I must apologize that I wasn't able to access the chat earlier. So we've got a couple more questions for Dr. Telen, and I hope you don't mind waiting, Dr. Potter, for your questions to come after, if that's all right. Yeah.
Yep, go for it.
Okay, lovely. So the one question from Kate Gardner to Dr. Telen was, where will we be in 10 years' time in high-income countries? Will most patients have received transplants or gene therapies, or will they be on multi-drug treatments? Have you got a crystal ball, Dr. Telen?
Well, I think that crystal balls are hard to come by, but I think that most people will still be on therapies, hopefully maybe multiple therapies, but you know, I think if you look at the time course of bone marrow transplant or hematopoietic stem cell transplant, you know, we've made a lot of progress, but we're still, you know, for a variety of reasons, but not just because of donor availability. We're still, you know, we're certainly not having transplanted all the people who have potential donors or who qualify and have potential donors. I think there's a lot of reasons why, and I think that's going to be true in the gene therapy as well. I mean, maybe it will be less true in 20 years, but I think in 10 years, we're still going to be mostly treating patients with the drugs that, you know, are either available or on the horizon in, you know, the next 5, I suppose.
Thank you. And I have a question from Dr. Rachel Cassadu, who wants to know, does gene therapy have a role in stroke prevention in sickle cell disease? And I think that was for you, Dr. Telen.
Well, I think that's an interesting question. I think if you have it makes me think mostly about pediatrics, which I don't do, but simply because our screening for stroke prevention is something that we do in pediatrics, and at least at our center, if there's a conditional Doppler result, the patients are generally put on hydroxyurea, and we see some, but fewer and fewer patients progress to the high risk state and then go on chronic transfusion. But I think that if the choice is chronic transfusion versus gene therapy, maybe not now, but sometime within the next 10 years, gene therapy might indeed be the way to go rather than chronic transfusion. So the answer would be that might be a good indication at some point.
Thank you. I think I have a question from, there's a hand up from Odessiri. I don't know if you've got a question for Dr. Telen or Dr. Potter. If you could just speak up, maybe have your camera on if you can.
Okay. It's a question for Dr. Potter. Hello, Victoria.
Hello.
It's just to ask a question in terms of with the sibling transplant. What's the preference and what's the outcome in terms of when people get from a matched donor compared to from the parent or the dad or the mom? What are the outcomes?
So if you got a fully matched donor, that would be a sibling. If it was from your mother or your father, then that's going to be a half match.
Or
And
what's
so
your preference?
The preference at the moment is sibling, and those are the patients that probably have the best outcomes, the lowest rates of GVHD, and a really easily deliverable protocol. For patients with a haploidentical donor, that one at the moment is still not funded for patients in the UK. For adults, it's funded for children. And we hope that we will be able to offer that, but it will be as part of a clinical trial. And so I think for us in the UK, that's really going to be the best way to assess the outcomes. But I would say that for both of them, the outcomes in terms of overall survival are good. It looks like we can deliver these approaches with relatively low rates of GVHD, although the GVHD is likely to be higher with a haplo and the intensity of the protocol is a bit more with a haplo.
Okay. That's what I just...
Does that answer?
Yes.
Thank you. I think there is a question from Sarah Stewart Smith. I can read it out, unless Sarah wants to say it out. Is that a question for Victoria, wasn't it, Sarah?
I can see it actually.
Yeah.
To say, so you seem to be saying there's no particular operation limit as long as there's no other organ function, because you had somebody of 65 in one of them, didn't you?
Yeah, so that most recent publication, so I would totally agree, no upper age limit, as long as the patients are well. Clearly, you have to have, you know, case-by-case conversations because, you know, an older patient may find it harder to tolerate, but it will be assessed upon their organ function, and then it's a risk versus benefit for that individual patient.
And in terms of their donors, because often they've got quite old donors then, is there an age limit on a donor? Do the stem cells get less active?
The younger the donor, the better. So we don't have an age limit, and if they've only got one option and that person's otherwise well, then they would still be considered. But if there was a choice of siblings and all other factors being equal, you would probably choose a young male.
Perfect. Thank you.
Yeah.
Thank you. Are there any other questions? And if there is, can you just speak up, because there's some glitch in the system. I can't always see all the questions. I don't see any questions. Okay, and we are nearly 4:30. So, there is a question from Dr. Telen. Or maybe a comment.
For Victoria, I was just wondering if anyone is doing umbilical cord blood stem cell transplant in the UK, and if so, has that been either tried or contemplated for sickle cell disease?
Yeah, so we do cord transplants for other indications, but it would be probably lower down the list for sickle cell disease, and the main issues would be much poorer immune reconstitution, and I suppose for adults, concerns about the cord dose. So I think we would probably really want to avoid that for reasons of cell dose and poor immune reconstitution. If it is theoretically possible, although again, it wouldn't be funded here.
Thank you.
Yeah.
But I can speak on behalf of the pediatric cohort, and I can say that the sibling cord transplants are in regular use if they are fully HLA matched. There is some experience in co-transplant as well, so the same sibling's cord is preserved until the sibling is a bit older to have a marrow harvest, and then the cord and the marrow are joined up together to provide the stem cells. So that's been used as well. An isolated cord has also been used, but it's a sibling cord, and often there is directed cord donation. So the families have asked for, for a prenatal HLA typing, which they have to pay for. It's not funded in NHS. So if it's prenatal HLA typing, or sometimes they just collect the cord anyway of a sibling and then use it if the sibling happens to be a match. Prenatal diagnosis with HLA typing, which is a PNDH, that is also available if you have the money to pay for it. So all of that in the context of sibling donors are being used at the moment. Excellent. Well, I think I can't see any more hands. So all it remains to be said is that I'm really grateful for everyone to attend, ask questions, interact with the wonderful speakers. And finally, thank you very much to Marilyn Telen and Victoria Potter for sharing their expertise and making us all, a little bit more knowledgeable about sickle cell disease. And thank you all very much for a wonderful session. Please do not forget to complete your feedback forms. We learn enormously from that and help us improve our future courses. Thank you ever so much and have a good afternoon, day, everyone. Goodbye.
Thank you.
Take care.
Bye.